ischemic stroke is a serious medical emergency that requires prompt assessment and management. For this reason, the American Heart and American Stroke Association have combined efforts in order to improve stroke care. A model has been created to guide this process. Everything starts from the moment EMS is contacted and the patient is brought to the ED. On arrival, the patient gets seen by the ED staff and the stroke team to evaluate the patient. A CT of the head without contrast is promptly obtained, and after reviewing the data, we decide if the patient is a candidate for TPA. If indicated, our goal is to be giving the medication by 60 minutes or less, keeping in mind that the patient needs to present within 3 hours and in some cases up to 4.5 hours from the last known well. Now, let's recreate a brain attack and see how all these events come together at Penn State Hershey Medical Center.
The stroke team gets notified when the patient has arrived to the ED, and most of the times is pre-notified by EMS. At this moment, the team rushes to the ED to meet the patient. The team gathers around the patient to get information from EMS. We call this the huddle. As a team, the neurology resident and nurses gather the pertinent information including last time known well, symptoms at onset, past medical history, and home medications, among other things. The physician assesses the patient using the NIH stroke scale, and lab work is initiated. Often, these steps happen simultaneously. Once the patient has been secured in the CT scanner bed, we promptly obtain a CT of the head without contrast. This study will help us to quickly evaluate for obvious intracranial bleed, trauma, extensive territory infarction, or other intracranial abnormalities that can preclude the use of TPA. As the radiologist is reviewing the imaging, the neurology resident gathers all the information and reviews all the contraindications with the patient. And very often the family is available. Families can provide priceless information that very often will be critical in determining patients' eligibility for TPA. The neurology resident immediately contacts the attending to discuss the case, and a decision is made on whether or not our patient is a candidate for TPA. If the patient is a candidate, we promptly get consent after reviewing the risks and benefits. We obtain the patient's weight and calculate the TPA dosing. The nurse will be preparing the medication, and after confirming the patient's blood pressure, we will infuse the bolus dose over 1 minute, followed by the maintenance dose over 1 hour. Remember that blood pressure management will be important after TPA. We re-evaluate the patient after giving TPA and consider the need for a CT angiography and CT perfusion. This patient may be a good candidate for endovascular procedure if presenting within 6 to 8 hours of last known well for an occlusion in the anterior circulation, and 12 to 24 hours for posterior circulation. But what if your patient was not a candidate for TPA? Well, you could still get a CT angiography and CT perfusion to evaluate for an occlusion. This will warrant a consultation to the neurovascular intervention team, who will evaluate if there is an occlusion amenable for endovascular intervention, in which case the patient will be taken to the neurovascular intervention suite. Remember that the ED will be helping you, and they will be placing the initial orders for labs, imaging, and urgent medications, and will be in charge of the initial stabilization of the patient. If the patient is deemed to have a stroke, use our admit order sets and also complete the forms. If your patient is admitted to the ICU, remember to give them a call and give them sign out. Remember, at all times, communication is the key.